Okay, we're back. We're going to have a conversation now about nutrition and a real introduction to nutrition. And there's a little bit of history with this topic, and it'll actually go with the next two videos that we're going to do. Way back when, like years and years ago, when I took part one, when, you had to bubble in bubble sheets with a pencil and stuff like that, the chemistry section was purely a chemistry test, a lot of basic chemistry, and I don't even really remember there being a lot of biochemistry on it. Then, over the years, a little bit of nutrition got added and a little bit more. So, at first, we started teaching a little bit of nutrition in the biochemistry class to cover that. Then, as it got to be a little bit more and a little bit more, we moved the nutrition class from a quarter, because we were on quarters then, after the boards, to one before the boards, because we realized you needed it for part one. Way back when I did it, you didn't. So the fact that we took it after part one really didn't matter. So we moved it, and that worked really well. So I took a lot of the nutrition out of biochem that we had added in drips and drabs. But then I realized a little bit of redundance doesn't hurt, and it also gives you a little bit of a jump on your nutrition class. So you will take nutrition before you take part one, but we're going to just kind of barely introduce a few concepts just to have them under your belt before you do take nutrition. The other thing is, a little bit of a disclaimer on this is you do the really cool stuff, the interesting stuff in your nutrition class. This is a lot of definition-y kind of stuff. So I'm letting you know that because I don't want you to form any opinions on nutrition. I like it, I don't like it, whatever, based on this. It's not very representative. It's just very, very foundational. Nutrition, I think, is really, really interesting because it's really just applied biochemistry when it comes right down to it. So I think you'll really like it. I think you'll really enjoy it, find it very interesting. But we're going to do some foundational stuff, so don't form your opinions yet. Wait until try 4 when you actually get there. So we're going to talk a little bit about nutrition standards. How much of what do you need based on a group, whether it's gender, age, whatever. So we're going to talk a lot about dietary reference intakes. So there's a few. There's the dietary guidelines for Americans that we update every few years. They focus on health promotion and chronic disease prevention, supposedly. And they're supposed to help the general public focus on appropriate food and lifestyle patterns. There's My Pyramid, same thing. They're all about telling the general public how much of what they should eat. So, the reason we talk about this, the reason we bring this up is that's a question you're going to get in your office. How many carb grams should I be eating in a day? How much vitamin B12 should I be getting in a day? Things like that. So when you're answering that question, you're answering based on an intake goal. And we're going to talk about that. And these are some kind of loaded ideas and loaded definitions. So we have our dietary reference intakes. How much of what does a particular population need? So we can have a recommended dietary allowance. That serves as an intake goal for all healthy people. Well, that's loaded. What are healthy people? And that's something you've probably talked about, if not you will, in your philosophy classes. Am I healthy if I'm disease-free? Am I healthy if I'm symptom-free? Or am I only healthy if I'm operating at my absolute optimum condition? So that's something you're going to have to decide when you're having these conversations with your patients. We have something called an adequate intake. We don't really have enough information to tell you exactly what you should be taking, but that's what we think right now. We're not ready to call it a recommended dietary allowance or an RDA yet, but we're working on it. Also, before I forget, let me bring up, make sure with all of these definitions that have abbreviations, and we've said this before, but I'm going to continue to say it. Make sure you know these things both by the definition or by the proper terminology and by the acronym. Because I might ask you, or somebody else might ask you, what serves as an intake goal for all healthy people? And you know, RDA. And I give you recommended dietary allowance, recommended daily allowance, whatever else I could think of that RDA would fit, and you're stuck. So anything with an abbreviation, especially one that's easy to make distractors to fit, make sure you know exactly what it means. Don't just know it by the definition, or by the acronym rather, I'm sorry. We can have a tolerable upper intake level. That's really the concept of just because some is good doesn't mean more is better. So it's an upper level, the line that you don't want to cross between how much of something is okay and when you're going too far with it. Fourth one is an estimated average requirement. It's really expressing the same information as the RDA, but expressing it based on the middle of that population group rather than most of that population group. Okay, so our dietary reference intakes estimate the amount of nutrients required to prevent deficiencies and maintain optimal health. And again, what's the definition of optimal health? So it's loaded there. So you can see where, to answer your patient's question, how much of what should I be getting? There's an awful lot of gray areas in that. So we have some parameters with that. We have the RDA, EAR, adequate intake, and upper limit. We're also going to focus these on a specific age group, gender, physiologic state in some cases. So here's the 4 DRIs summarized. Notice with estimated average requirement, it's the amount that satisfies the needs of 50% of the people in that population group. I said age group here, but population group, the middle. For recommended dietary allowance, it's what most of the group needs, 97, 98% of the group needs. So really expressing the same information, expressing the statistics a little bit differently. So going through the same things again, estimated average requirement, average daily intake to meet half of the individual's needs in that particular group, recommended dietary allowance, what we need to meet the needs of most of that group based on the food pyramid. And here's where I'll throw down the gauntlet to you a little bit. What do you think of the food pyramid? If you have a patient come in with the food pyramid, say, what do you think, doc? How are you going to answer them? And I know you don't have a lot of time right now, and it may be early to be answering them, but particularly when you're taking nutrition, Google the food pyramid, take a look at it. What would you say to a patient who came in with that and said, what do you think, doc? Is this what I should be doing? You need an answer for them. So adequate intake, we don't really know what you need, but it's what we know right now. Tolerable upper intake level. Some is good doesn't mean necessarily that more is better, so we don't want to go above certain amounts. We can have adverse health effects if we have too much of certain things. So most nutrients do have a set of dietary reference intakes. A couple more terms. Estimated energy requirement. How much fuel, energy, do I need in a day to do all of the stuff I do? Everything from running my vital organs, keeping me alive, processing, digesting, absorbing my food, and then whatever physical activities I do. And of course, this is based too on gender, age, the usual things that put you in a different group. So we're going to look at, ideally, we want calories in equal calories out. Doesn't always work that way. This depends on your genes, your metabolism, what you're doing, behavior, things like that. Food labels estimate it to be 2,000 calories. So be a little careful here, and this is something we need to bring up. When we're talking about food labels, 2,000 calories is equal to science 2,000 kilocalories. So when you're in the lab and you're doing your calculations like you did in general chemistry and everything, you're using kilocalories. We'll call them sometimes capital C calories. On a food label, what they call a calorie is really a kilocalorie. I guess maybe that makes nicer food labels than saying kilocalories. I don't know why they do it, but that's what they do. Okay, the next thing is the acceptable macronutrient distribution range. Loaded, loaded, loaded here. How much carbohydrate should I be eating? How much fat should I be eating? How much protein should I be eating? What's interesting with this is, well, actually a lot of things. It's, again, how much fat, carb, protein do I need to keep me healthy, reduce the risk of chronic disease, all that. Well, what is healthy? We're trying to reduce the risks associated with excess consumption. And this varies. We're trying to take the protein in to get enough amino acids for growth and everything. Loaded, loaded. What are you going to tell me as your new patient? How many carb grams should I be eating, doc? Oh yeah, I need 70 grams of protein. Can I just eat, 5 eggs for breakfast? Am I going to absorb it all at once? So there's a lot of other issues there with this. So again, pay attention in nutrition class, do some research. How are you going to answer me as your new patient on all of this? This came straight out of Lippincott, one of the textbooks we're using for this class. Do you agree with it? And notice something else with it. We don't say what carbohydrates, what proteins, and what fats. So we're not saying anything about quality, just quantity. So again, pay attention in Dr. Krabbe's class. Fill this in for yourself. Male patient, female patient, elderly, baby, whatever. And be prepared to answer these questions. Okay, the next concept we're going to do is glycemic index. Little bit of a dated concept, but it is something you need to be aware of. So the story behind the glycemic index is a group of researchers, Canadian researchers, I don't know what school, but they were sitting around and saying, what should we tell our diabetic patients to eat? And the logic was, we want to lower their insulin demand. So what happens with food containing glucose is you eat the food, you go through all the steps and everything that we're going to do in a couple modules, and that glucose enters the bloodstream. So that blood containing glucose goes flowing through the pancreas. The pancreas sees the blood in it and releases insulin, the hormone insulin. What insulin will do, among other things, is it will facilitate getting that glucose out of the bloodstream into the cell. So the problem a type 2 diabetic has is that the cell is resistant to that insulin signal saying, let the glucose in. So what'll happen is the glucose will be in the bloodstream. You'll do that process of the pancreas releasing insulin. The insulin will go up to the cell and try to facilitate letting the glucose in. The cell is resistant to that signal, so you don't let it in. So you have the insulin then in the bloodstream, and you have still the glucose. It all goes flowing through the pancreas again. Pancreas releases more insulin. For a while, that will allow the glucose into the cell. You just take more to get the job done. And as you become more resistant, it takes more and more and more to get the job done. At a point, though, you're not going to be able to make the more and more that you need. So what you'll end up with is a ton of glucose in the bloodstream, a ton of insulin in the bloodstream, and you're not getting glucose into the cell. That's the point at which you've crossed the line from being insulin resistant to diabetic. So while you're insulin resistant, bordering on diabetic and everything, you're up and down with your insulin demand. And type 2 diabetics can have some response to insulin. But what you don't want is this up, down thing where, let's say you eat a big carby breakfast, you need a lot of insulin, get the glucose into the cell, don't eat until lunchtime, need less, big carby lunch, need more, don't eat until dinner, need less. So what they were trying to do is they were trying to figure out what they could tell patients to eat that would take a while to release that glucose from the food into the bloodstream. So rather than eating something that went from the point at which you put the food in your mouth to the point at which the glucose was in your bloodstream really quickly, they wanted to tell their patients to eat things that, say, the glucose was all tied up with fiber, that took us longer to process. So rather than the glucose being a big whoosh of glucose into the bloodstream, there's a medical term, whoosh, rather than a lot of glucose going into the bloodstream all at once, it would be just a gradual release over time. If you have a gradual release over time, you need less insulin, you need just kind of a sustained lower amount over time, rather than a big amount, none, big amount, none. So what they did is they developed what's called the glycemic index. They called, depending on which numbers you want to use, I don't know if I should say which glycemic index, they had two reference points and a glycemic index that went with each. One was plain white bread or the other was pure glucose. And they looked at how long that took to go from the point at which you put it in your mouth to the point at which the glucose was in the bloodstream, looking for insulin or exerting an insulin demand. Then they looked at all the other foods relative to that and how much slower they went from the point at which you put them in your mouth to the point at which they were glucose floating in your bloodstream, exerting an insulin demand. So what they ended up figuring out with that, or categorizing with that, is they quantified. So you had a rating on all these foods. If the food went from being food you put in your mouth to glucose in your bloodstream at a high rate of speed, that was called a high glycemic index food. If it went from being food you put in your mouth to glucose floating around in your bloodstream at a low rate of speed, that was considered a low glycemic index food. So what they thought or said was that low glycemic index foods have the slower rate of digestion and absorption of the food's carbohydrates, or glucose in particular. Usually equates to a lower insulin demand. And what they were trying to do is improve long-term blood glucose control and blood lipids. We'll talk about how lipids come into play from glucose later. So what we're trying to do is we're trying to eliminate that up and down in blood sugar that results in up and down in your insulin levels. We're trying to prevent insulin spikes, trying to prevent insulin resistance, and all the research was really done trying to prevent type 2 diabetes. So let's go back and talk about it for a second. So a couple things with this. One is glycemic index is the quantifying system. It's not really the best route for mitigating insulin resistance or type 2 diabetes. So what more current research is finding? That intermittent fasting is doing a much better job. The logic with intermittent fasting is If you're fasting for whatever time period, you're giving the cell a break from the insulin. So it's kind of like insulin resistance is kind of like, let's say I just yell all the time. I'm always yelling and screaming. If I'm always doing it, you're not going to take it seriously. You'll tune me out. You'll get resistant to me. That's kind of insulin resistance. If the cell is getting bombarded with insulin all the time, tunes it out and becomes resistant to it. But if all of a sudden I scream right now, you're going to probably take notice. I don't scream hardly ever. So you're going to take notice. You're not resistant to it. I never scream. So I've got your attention then. That's the logic with fasting. If we're fasting for whatever portion of the day, the cell's not getting any insulin signal. It allows it to become more sensitive to it. So now when it gets insulin, it'd be like me yelling, it'll take notice. It's not as resistant to it. So that's been proving much more effective in mitigating insulin resistance and type 2 diabetes. So anyway, we'll talk about diabetes more next try. We'll talk about it more in try 3 in endocrinology, and we'll talk about insulin more. The other thing is, don't confuse glycemic index with glycemic load. Glycemic load is the amount of glucose in a serving of whatever particular food. That one's a little bit loaded in what do we define as a serving. So if you try looking up the glycemic load of foods, sometimes you see different numbers because the serving will be defined differently. Okay, next one, protein digestibility corrected amino acid scoring. We're going to have, actually let me back up with this a little bit. We're going to talk about essential and non-essential amino acids and fatty acids. And as soon as I say that, I know a lot of you guys are thinking, hang on here, that terminology's over and done with. Let's be current, let's be modern. And we should be saying dispensable and indispensable. You're probably right, but here's the deal we made. We're not 100% sure that you won't see essential and non-essential in questions. So I don't want to use dispensable and indispensable, then you get essential and non-essential and think, what's going on here? So Dr. Krabby and I had a conversation, and we said, why don't I stick with essential and non-essential, the older terminology, so you're familiar with it and comfortable with it, totally acknowledging that it's older terminology. And he'll use dispensable and indispensable, so you're familiar and comfortable with both. So I'll be doing essential and non-essential. So what an essential anything is, whether it's an amino acid, a fatty acid, a vitamin or mineral, what it is something that you need to eat because we don't have the ability to make them. You have to eat your essential amino acids, but you can make your non-essential. You have to eat your essential fatty acids, and then you can make your non-essentials. You have to eat vitamins and minerals because they are essential. We have no way of making them. So the protein digestibility, corrected amino acid scoring, is a scoring or a rating on a particular protein. Remember, proteins are made up of amino acids, of a particular protein on whether it's giving you essential amino acids that you need. This, for a run-of-the-mill carnivore, really isn't an issue. If you're eating meat, you usually don't have an issue with your essential amino acids. If you're vegetarian or vegan, this is something you will be thinking about to make sure that you are getting the essential amino acids that you need from the foods that you are eating. Okay, what happens if I exceed my acceptable macronutrient distribution range consistently? I get something called obesity. And we're going to talk about that more. And this is another one that I'll throw down the gauntlet and tell you to go decide or research what causes obesity. Am I just too lazy to push myself away from the table, get off the couch, and get my head unstuck from the refrigerator? Or is there more to that? Is there an environmental component? Is there a hormonal component? Your opinion on that will influence how you handle obese patients, how you manage obese patients. So we'll talk about it more next try. But when you have some time, go research that, see what you think on that. It's back to this doctor thing being a judgment thing, not an algorithm thing. So if we have obesity or get obesity, we can deposit that excess fat a couple of different ways. This is the old apple and pear argument, but I want you to have the definitions for it. If I deposit the extra fat in the upper part of my body, this is the apple, that's android obesity. So that's the extra fat located in the abdominal area, central abdominal area. That's the one associated with the greater risk of hypertension, high blood pressure, insulin resistance, type 2 diabetes, dyslipidemia, heart problems, and everything. The fat cells tend to be larger and they tend to be more responsive to hormones. The hormones are the whole key in that. If I deposit it in my lower body, this is the pear half of the argument. That one's more benign. More common maybe in females, straight out of the book, I'm not sure I agree with that. More difficult to lose because it's not responsive to hormones. So it's kind of a double-edged sword there. Easier to lose, or more difficult to lose, but less of an issue hormonally or health-wise. And like I said, we'll come back to these. Okay, body composition. We're going to talk about this just a little bit. Your body size and shape are very individual. Depends on your genes, your diet, your exercise, things like that. Body types. I don't know if this is something, here's the background on this one. It is something that you do need to know for the chemistry section of part 1 of the boards. It was actually quicker to throw a slide in with the definitions than it was to go researching to see if you got it anywhere else. My justification there also was redundancy, repetition never hurts. So 3 body types, you may get them later, I don't know, are defined here. So the slender body types, the ectomorph, mesomorph is the more muscular, endomorph is the rounder, more body fat accumulated body type. Okay, let's talk about body composition for a minute. Some of you guys have done a lot of work with this. You're made up of some lean body mass, some fat, some water, and some bone. And there's different ways of figuring out how much of what. One is the Archimedes principle, where they dunk you in a cold pool, typically wearing as little as possible, and I'm not sure why it has to be freezing cold, but it always seems to be, and see how much water you displace. We could use a DEXA scan, more commonly used for bone density. We can use DEXA scan. We can use a bioelectrical impedance system, often used in clinical settings. That's the one where you go and join LA Fitness and you hold onto this thing, put your weight and height in and stick your arms out, and it will say your whatever percentage body fat. And just so you know, you can go drink a bunch of water and change the number. Or you can do a lot of measurements, body circumference, skin fold, thickness, things like that. Some of you guys have done this. This is a real skill. And if you're good at it and quick at it, it might be something you decide to do in your office. You have to have the right pressure, pinching, I think 21 different places, and measure how much skin you pinch. You'll measure circumferences of different parts of the body and plug it all into usually a spreadsheet. Gives you an estimate of body fat and muscle. Patients love this because they love to quantify things. So if you're quick and good at it, or even better if you have a CA who's quick and good at it, you can do it for the patient have them do whatever program they're doing for whatever time frame you decide, do it again. And it's a nice little progress check for them. But what we're trying to get is body mass index. It's an indirect measurement of body fat. I know you hate this formula as I put it up, but it still shows up here and there, so I just want you to be comfortable with it. Doesn't work for athletes, doesn't work for a lot of people, but all you're doing is basing the BMI on height and weight, saying if you're over 30, you're obese. Like I said, doesn't work for a lot of people, particularly people with a pretty high muscle mass. Okay, we'll talk about obesity when we talk about diabetes. What happens is you go through some reactions and processes that we haven't done yet, but we'll do next try. And you're going to take extra fat. We'll talk about what kind of molecule it'll be packaged up in, and you're going to ship it off to adipose tissue. When we're making the cells in the adipose tissue, we'll keep making them bigger, bigger, bigger till they hit a certain point, and they'll divide, and we'll make new cells to keep making bigger, bigger, bigger until they divide. A couple things with that. According to our textbook, and there's research on both sides of this, once you have those fat cells, you're stuck with them. When you shrink them down by losing weight, they want to get bigger again. You're putting them in an abnormal state. So some research says that that's why it makes it harder then to keep the weight off. Again, go do your research and see where you fall on that. Adipose tissue, the adipocytes, are actually thought to be a little tiny endocrine organ. And there's some argument on that, but they produce some hormones. Leptin is a really, really interesting hormone. Leptin is the only hormone that kind of says, you're done, you've eaten enough, push away from the table, that's it. And it was discovered, I think back in the 90s, I could be wrong on that. And when it was discovered, it was thought to be like the holy grail of obesity. You know, if you're obese, you must have a leptin deficiency. So there was some research done, or a research project done, where the researchers took a group of very obese patients, like well over 300 pounds, and gave them leptin. And initially they lost a bunch of weight and lost it fast. They thought, that's it, we've got this figured out. We've got the answer to obesity. But then as quickly as they lost that first amount of weight, they plateaued. And that was it. They kept giving them leptin, but no change in their weight. And the leptin was the only change in anything in their lifestyle. They plateaued. They realized they got resistant to it. So that kind of took care of that, but it was still an interesting project. So we'll talk about leptin more. We're going to talk about some hormones that are blamed for insulin resistance. We're going to talk about an appetite stimulating hormone. Okay, next thing we're going to talk about is insulin resistance. So, over the years, we've had different names for this, and this is something we'll talk about more next try. We'll talk about in endocrinology in try 3. So, we tend to call it insulin resistance now, which is probably the most descriptive term. Has been called metabolic syndrome, has been called syndrome X. So, insulin resistance is kind of the root with it, associated with abdominal obesity and the signals that the fatty tissue is sending out. So it's a combination of insulin resistance, glucose intolerance because we're resistant to our insulin, hyperinsulinemia, remember hyper is too much insulin because we're resistant, making the pancreas keep releasing more and more and more, trying to get the job done. Dyslipidemia. Dys is wrong, lipidemia, and we'll talk about when we're doing the chemistry with diabetes exactly how that happens. Why do I have low HDL, good cholesterol, and high LDL, VLDL, bad cholesterol, and high blood pressure? That one's easier to do with the chemistry with it and talk about exactly what molecules cause all of that. Bottom line for it, though, is it puts you at an increased risk for type 2 diabetes and cardiovascular disease. So when we're doing diabetes, we'll talk about how do we get from glucose and insulin resistance, an insulin pancreas issue, to cardiovascular disease, hypertension, things like that. How do we go from the pancreas to the heart? So we'll leave that until we have the molecules and the chemistry and the story. So let's talk about obesity and weight reduction. Obesity is correlated with an increased risk of earlier death. It's correlated to an increased risk of a lot of things: diabetes, hypertension, heart disease, cancer, gout, arthritis, a whole bunch of things. And again, another gauntlet moment: is obesity causing all of these things, or is the same thing causing obesity as some or all of these things? So again, do some research, take some time when you have some time, and I know you don't during the term, but sometimes on a break you'll have a little bit of time. Go and do your research. This doctor thing you signed up for is a judgment thing, not just an algorithm. Okay, so weight reduction methods. And again, a little bit of research and a little bit of just patient stuff. Physical activity doesn't really change the scale significantly. But, hang on. Exercise is good, isn't it? Yes, it's good. It's fantastic for so many things. Not changing the number on the scale. And it's for a number of reasons. As you know, you build up muscle, which weighs more, has more mitochondria, which is good, but it's not changing the number on the scale. Caloric restriction. There's some arguments there. Do we want to do caloric restriction? Can we maintain that? What are we doing to our metabolic rates by doing that? Are we better off fasting? And I don't mean fasting in terms of caloric restriction. I mean fasting in terms of restricting the time that you're eating. So if you decide to get into weight reduction, weight loss in your office, there's a lot of things to consider there. Weight loss drugs, and with Ozempic right now, this one's huge. And I'm not advocating any of the drugs, but I think you should have some awareness of them. Pre-Ozempic, most of them worked as either an appetite suppressant or they decreased your processing, your absorption, basically made everything pass through your digestion more quickly. But I think you need to have that awareness to think about the side effects. Ozempic right now, everybody's after. But there's a lot of statistics showing, obviously, some really harsh side effects. So, of course, it's a risk versus benefit discussion. Also, a lot of patients just can't tolerate Ozempic. So, again, you're not prescribing it, but you need to have that awareness because you're going to have patients that will be on all of these things, asking you about all of these things. So if I'm a new patient, I come in and say, hey doc, I think I want to go take Ozempic. What do you think? What are you going to say to me? Surgery, gastric bypass, gastric banding, all that. American Diabetes Association's #1 recommendation for type 2 diabetes is bariatric surgery. There's a lot of research showing that after bariatric surgery, you lose a whole bunch of weight. Within 3 years, you put it back on and then some. What's your opinion there? What's interesting too is, at least from my experience, the patients that had it, how casually they talked about it. And I found that fascinating. When they told me they were going to have gastric bypass, they said it as casually as you or I would say, I'm going to go get a haircut or whatever. And like I said, I found that very fascinating because of the risks of it, the success rate or lack of success rate of it. You're going under general anesthesia with the risks of that. So anyway, again, a patient management thing. If your patient says, I'm going to go have bariatric surgery, what are you going to say to them? Okay, the next thing we're going to do is kind of physiology in 5 minutes. This is, well, let's back up with a little bit of history again. The national boards, as you probably know by now in part 1, are divided into 6 sections. And some of the sections are a little bit similar. And what I mean by that is questions drift back and forth. So it's not uncommon to see physiology questions in chemistry, chemistry and physiology, general anatomy and spinal, spinal in general. I guess you wouldn't notice spinal in general. So the next few slides are some of the things that students reported commonly came up in the chemistry section. We're going to discuss all of these things in a lot more detail in a couple of modules, but it's just a little conglomeration of stuff you can use later as review material of things that I repeatedly had students saying, well, I got this question, I got that question. So the first one is cells in the stomach and what they produce. So we're going to talk about it when we're talking about breaking down proteins, carbohydrates, and things like that. But the chief cells produce pepsinogen, which is a precursor, an inactive form that generates, pepsinogen generates pepsin. So we're going to see that in protein digestion. A goofy way of remembering it is the chief drinks Pepsi. The parietal cells make your hydrochloric acid. We want stomach acid. We actually need a low pH for the pepsinogen to get converted to pepsin. So the parietal cells make your hydrochloric acid to do that. The parietal cells also make intrinsic factor. Intrinsic factor gets really important in vitamin B12 absorption. And that's a patient thing too. Vitamin B12 is something we always need, but as we get older, we lose our intrinsic factor. We're not able to produce enough intrinsic factor. So if you get an elderly patient that's complaining about being tired all the time, check their vitamin B12 if you're in a state where you can do that. And if it's low, you can supplement their B12 and they'll feel a million times better. And all it is most likely it wasn't a matter of they weren't ingesting what should have been enough vitamin B12, they just weren't able to absorb it. And it's one of those things where it's such a simple thing for you to do that can make such a huge difference in that patient's life. Okay, the gallbladder releases some things we need: bile salts, bilirubin, BIL stuff, Bill stuff. So we're going to talk about that when we're talking about primarily with the bile salts breaking down fat, because fat doesn't dissolve in water, the oil and water thing. So we have difficulty breaking down these big blobs of fat into something that we can process and digest and absorb. So that's where you're going to see that. The pancreas is huge. We love the pancreas in biochemistry. So the pancreas makes some stuff we're going to spend a lot of time on. The beta cells make insulin. I would spell insulin kind of goofy to remember. I'd spell it binsulin. You could even make the little tail on the B for beta. Just a way of remembering that the beta cells produce your insulin. The alpha cells produce glucagon. Glucagon is the hormone that you release when glucose is gone. So glucagon, when glucose is gone, that's coming from the alpha cells. Also makes bicarbonate because we have that really acidic stomach and we're passing the contents from the stomach on to the next step in the digestive tract, and we don't want all that acidity. We need to get the pH back up. So when everything's heading into the small intestine, we're going to release some bicarbonate to bring the pH back up. Pancreas is also going to produce a bunch of other enzymes that we're going to see, and we're going to talk about as we individually go through carbohydrate digestion, protein digestion, and lipid digestion. Then we'll go to the intestine. The intestine absorbs stuff. So we get everything broken down, we get to the intestine, we have cells called enterocytes in the brush border, and that's where we absorb everything to either the lymphatics, the blood, depending on what we're absorbing and where it's going. We'll take the bile salts back in the intestine, send them back to the liver. We're not going to let them go past there because we need to reuse them. We're going to recycle. The liver does everything. So the goofy little saying, the liver's like everybody's mama, takes care of everybody and cleans up after everybody, is kind of true. Not kind of true, it's true. The liver worries about blood glucose levels, making sure everybody gets fed. And the liver takes back, gets rid of anything you don't want. So you're going to notice a very recurring theme there. As we get into our different processes, we're going to talk about, like we said when we were doing DNA and RNA, there's certain things you have to know about every process. Where does it happen, both on the cellular level and on the tissue level? And we're going to notice an awful lot of stuff as far as the tissue level goes happening in the liver. It's going to almost turn into your Hail Mary answer. You get asked where something happens, you have no idea, pick the liver. So in a way, this list is kind of our coming attractions, what we're going to be doing. If it doesn't happen in the liver, it probably happens in the kidneys, or it might happen in the kidneys also. And what I mean by that is an awful lot of the stuff that goes back to the liver when the liver is cleaning up after everybody, it sends to the kidneys to put in the urine and get rid of. So extra nitrogen will go out in the form of urea, go out in some other forms too. Extra acid, extra base will go out in the form of making the urine acidic or basic. We'll get rid of ketones, lactic acid, glucose overload if we happen to have it. So the kidney's job is to take stuff we don't want, put it in the urine, and get rid of it. We're also going to use that, we're going to start talking about lab values a little bit. And you have two approaches to your labs. One is, there's a crazy spreadsheet floating around and you can memorize it. And it looks horrific to have to do that. And it's stuff like, well, if it's up, whatever's up, it's a kidney problem, down, a liver problem, whatever. It's just crazy to try to memorize it. Or you can understand it, which is always the better approach. And you look at things like, well, I make this in the liver, I get rid of it in the kidney. Well, if I have too much, where's my problem? Well, if I have too much of something I make in the liver and get rid of through the kidney, my problem is probably in the kidney, and stuff like that. So we're going to take the lab values that you're going to look at, and we're going to break them down to, what is that molecule really? Where does it come from? How do I make it? Where do I make it? Where do I get rid of it? How do I get rid of it? And it becomes much more sensible, relevant that way. We have some special cases of fuel use, and we're going to get into this. But again, it's just things that students brought back to me here and there. The brain really, really likes glucose, and there's actually some research showing that that might be what makes you crave junk food when you're studying a lot. So I don't know if we'll get to talk about that one, but it's kind of interesting. After a few days, the brain can use ketones. A lot of people think 3-hydroxybutyrate, the ketone body, is kind of the optimum brain fuel. The transition from glucose to ketones is usually a little bit rough. That's the headache you get if you decide to go keto. So when you're a little disagreeable on day 4 or 5 of keto, that's usually why. The brain also likes amino acids, needs B6, things like that, to make its neurotransmitters. So we'll talk about that. Red blood cells are something we're going to talk about. They have kind of a limitation. When we talk about metabolism, we're going to say we do this process, the cytoplasm, this one in the mitochondria, things like that. Red blood cells have no mitochondria. So anything we do in the mitochondria, they're not doing. That has some real implications for them. So one of those is that we get most of the ATP out of a molecule of glucose in processes that we do in the mitochondria. So if the red blood cells can only do processes in the cytoplasm, they're not running very efficiently. So because they're not running very efficiently, that's why they struggle to maintain their portal membrane and can only do it for 3 or 4 months. So, everybody knows red blood cells only last about 4 months, but that's why. Because they're running that inefficiently because they don't have mitochondria. They can't do Krebs cycle, tricarboxylic acid cycle. They can't do electron transport. They can't do so many things because they don't have mitochondria. So we'll come back and talk about that. It's just kind of an interesting thing, I guess, about them. Muscles are such total scrounges. Muscles are like that kid that just eats everything. They'll use whatever they get. So any fuel source that's available to a muscle, they're all for it. During fasting, muscle can be broken down into amino acids for gluconeogenesis, and we'll talk about that, what gluconeogenesis is. It's making glucose for parts of you that need to live on glucose, such as your red blood cells, at times when you're not ingesting enough glucose. Pretty rare for us. We tend to eat enough carbs that you really don't have times that you're not ingesting enough glucose, but it can happen. Muscle will get broken down into amino acids, but those amino acids weren't meant to be fuel. It's kind of a metabolic dire straits situation when you're doing that. They're not meant to be fuel. Creatine phosphate, we're going to talk about when we get there in the context of muscle. We'll talk about creatinine as well. Okay, we're going to talk about the heart. The heart's a muscle, and in some ways, or obviously function-wise, it's a really, really special muscle, really, really special function. In some ways, though, on the molecular biochemical level, it's kind of just another muscle. And I know that sounds like a really strange thing to say, but what I mean by that is a lot of the basic, how does it get energy, the ATP that it needs from fuel, from food that you ingest, is the same as any other muscle. And I'm pointing that out because sometimes when you're answering questions on the heart, you kind of want to neglect your basic biochemistry a little bit because you'll think the heart's really, really special. It's got to do something really, really special, really, really different. Yeah, it is really, really special, but on the molecular biochemical, getting energy to pump, to beat, it's kind of just another muscle. So a lot of the fuels, the processes, the reactions, the stuff on that level is no different. So just kind of bringing you back to that. We'll do that again. We're going to talk about diagnosing heart attack, creatine kinase, some of the molecules that are and have been in the past used to diagnose heart attack. We're going to talk about heart disease. What we're going to do there is we're going to get through all of our carbs to energy, protein to energy, fat to energy first. So we have all the chemistry and we have all the reactions to do that. Then we'll come back and say, okay, well, what are we doing that causes our cholesterol to not be the way we want it? Too much bad cholesterol, not enough good cholesterol. What causes arteriosclerosis? What causes plaque in the blood vessels? How do we do all that? So I'll talk about it, and your physiology is going to talk about it as well. And this will be one of the places where we're going to come up to the edge of that big wide gray line that separates biochem and physiology, and probably biochem, physiology, and pathology. But we'll do the reactions, the chemistry, phys will take over, patho will take over from there. Okay, so that's it for part of our little nutrition intro. We're going to do bioenergetics 2 next, which is going to be really, really similar. A lot of foundational, what to expect, just get a foundation stuff for your nutrition class that you'll do in Tri 4. So that's where we'll go next.